Okay.
Okay, your microphones are now turned on.
Do you want to should Catherine on?
No, what is it?
Everyone on the line or good morning.
I can't really see the screen.
Yeah, and I don't really know.
Okay, well, I'm registered for the meeting and I should have a chat.
Well, you should.
Somebody got to take this one.
Oh, no, it was. Yeah.
Where would you like me to go?
They're moving chairs.
Seeing about the gas wireless 29. See my iPhone.
Because I'd have been talking about
It's really hard. Stand in it.
well.
That's okay. Yeah, I appreciate it.
Okay, good morning. Welcome to the second day of the ICD-10 Coordination and Maintenance Committee.
This meeting is being recorded.
And now that we know that the meeting is being recorded, I will also let you know that the microphones are in the ceiling and they will be picking up conversation. So just want you to be aware that if you are thinking about having any sidebar conversations, they too may be picked up as part of this live recording that is also archived. So just so that you know this. We have a number of great topics to cover today, so I'm going to limit my welcoming remarks for this morning's session so that we can get on with our day, but a few important announcements. At about 10:15 this morning, there will be a shelter-in-place drill. We will not be affected by the drill. We will continue our meeting, but you will hear the announcement letting us know that the drill is starting, and then you'll also hear the announcement when the drill is concluded. So don't panic, don't head for the door. We'll continue the meeting, but wanted you to be aware that this will be going on right outside our doors. The other thing that is important to note for today is, I know for those of you who have previously attended, you know that we usually go until 12:30 and have a 1-hour lunch break. That changes for today. We will have a hard stop at 11:30 this morning, and then return from lunch at 1 o'clock. There is another meeting in this room when we take our break, so you will need to take your belongings with you when you head out to lunch or downstairs to lunch. Ooh, mood lighting. And so just so you know, and we apologize for the inconvenience, but you realize there are a number of meetings going on simultaneously, and we're sort of not in control of how the rooms are scheduled. So just so you know, at 11:30 it will be a hard break, and we'll come back from lunch at 1 o'clock. Those needing breaks, please feel free to get up and use the restrooms, but we won't be taking a hard break either. So just wanted you to be aware of that. The timeline is in your handouts. It's posted both in Part 1 and Part 2. Again, the important issues for the timeline are the due dates for comments for this meeting, all proposals being presented for the diagnosis proposals are for consideration for October 1, 2020. They are not for October 1, 2019. And again, the dates are in the handout, but we would like to have your written comments by May 10, 2019. Again, and that is to ensure that we have your public comments and that we can consider those comments as part of what may need to occur should a presentation need to be brought back to the September meeting. Addenda files will be posted in June as usual, but we will make an announcement closer to the posting date so that you can look for that. And hopefully many of you have already signed up for Gov Delivery so that you actually get notification as to when files are actually posted. The deadline for the meetings that are to be considered for the September 2019 meeting is in June, and again, that is in your handout materials. Because of the number of proposals we have today, the addenda materials are in the handouts. However, we may not cover them today as part of the actual presentations. Also, as a reminder, security has reminded me previously to remind you, please no videos or picture taking. And they're quite serious about that. So wanted to remind you so that you don't have somebody from security approaching you to tell you that personally. And with that, I will now turn it over to CMS Noel. For those of you who were not in attendance yesterday was not a full day. The CMS portion for procedures ended at 1 o'clock, and we had some holdovers for CMS, so they will go first, and then we will go into the diagnosis proposals. Noel?
Thank you, Donna. Hi, good morning, everyone, and we thank you for your flexibility today in our small quarters. As Donna said, we're going to finish two things that were carried over from yesterday, the ICD-10 PCS addenda items, and then one of our topics. So the first on our agenda this morning will be the PCS addenda items. If you have the packet or you're following that online from yesterday, it's page 60 is where we will be. And moderator, can you open the line, please, for Rhonda Butler?
I'm sorry, you were like all of the lines unmuted?
Rhonda, are you on?
I am. Can you hear me?
I can, thank you. Okay, so I'm not sure what you can see. I may have to scroll through your slides, while you're doing your presentation. Is that okay? And you can just let me know what page you're on and we can scroll through them.
Sure.
Okay.
Yeah, I've got YouTube up on the other computer, but there's a bit of a delay. So I'll just make sure I tell you what page I'm on.
Okay, thank you. Thank you.
Thanks, Noel. Good morning, everyone. I think this is the first time ever that I've been first on the agenda, and I'm especially pleased not to have done what everyone did yesterday, which is talk 5 times as fast as they normally would. That was amazing, but not something I would necessarily want to try myself. The addenda are pretty straightforward, one of the shorter ones we've had recently, and so I'll just step through them in the usual way, and I think we can take questions and comments at the end, but I'll let Noelle handle that, whether we have time or not.
I got it, Rhonda, so we're ready for you.
Okay, so we're starting at the top of page 60, and there's just one entry that's cross-listed in the index and the body part key. That is to add the anatomical site submandibular space, and the instruction is to use subcutaneous tissue and fascia of the face. And that's listed in the index addenda and the body part key. Next, there's a slight change to the explanation in the root operation control. The proposal is to delete that explanation, that the site of the bleeding is coded as an anatomical region and not to a specific body part, because that explanation no longer applies to all the uses of the root operation control. Moving on to the table addenda, the first one at the bottom of page 60 is extirpation of upper and lower jaw. The table is 0WC, the anatomical regions body systems in med-surg, and the root operation is extirpation. The proposal is to add the body part values upper and lower jaw to allow capturing of detail for things like evacuation of a semi-solid hematoma from those spaces, mandibular and maxillary. And then the table mock-up bleeds from page 60 to the top of page 61, but on the top of page 61 is where you can see the upper jaw and lower jaw body part values added. Next, we have a couple of proposals to add the coronary artery body part values. The first one is to add them to the root operation supplement. All 4 of the coronary artery body part values, 0, 1, 2, and 3, specifying 1 artery, 2 arteries, 3 arteries, and 4 or more arteries. So the idea is to enable capture of specific supplement procedures for the coronary arteries so that you don't have to default to the more general heart body part value. That supplement, and then moving on to the top of page 62, the same deal for the root operation insertion. So the table is 02H. The proposal is to add the specific coronary artery body part values, and the 2 devices that are being added initially to this first row in the table. So it creates a new row, and the device values are intraluminal device and other device. Moving on to the top of page 63, the proposal is to add the root operation, body part values for the sinus body parts for the root operation supplement again. So this is table 09U. And you can see all the sinus body part values listed out there. It's the 3rd row in the table mock-up, creates a new row. So again, to enable capturing that kind of detail where the sinuses are reinforced or augmented with some sort of tissue substitute. Okay, moving on to the top of page 64. There's a proposal to add a qualifier value to one of the root operations bypass tables. We've been doing a lot of that, and here's one more. The table is 021, heart and great vessels, and the proposal is to add the innominate artery qualifier for the thoracic aorta body part values. So for both the descending and the ascending and arch body part value, the proposal is to add the innominate artery as a qualifier to enable capture of that bypass from the thoracic down to the innominate. All right, next is the top of page 65, root operation transfer. The table is 0DX, so we're in the gastrointestinal body system. The proposal is to add the qualifier vagina to the transfer table 0DX for the body part value large intestine. And this enables capture of procedures where the intestine is transferred down into the vagina to construct vaginal body part for patients with congenital anomalies, typically. All right, the next one, we're moving on to the administration section. All those previous tables, as I'm sure you know, were for the med-surg section. In section 3, the proposal is to delete the peripheral artery and central artery body part values from the transfusion table generally. So this is table 302, transfusion. And the rationale there is that although these have been in the tables, I think from the beginning, they are clinically invalid. The numbers are cumbersome and are adding complexity to the tables. So the proposal is to delete all those codes. And you can see in the table mock-up about row 4, so we're on the top of, no, about the middle of page 66. There's a row containing peripheral artery and central artery. Those would be deleted for all those substances. Okay, and the last one, we're on the bottom of page 66. Also in the administration section, but this time in table 3E0, the root op introduction. The proposal is to create a new qualifier, hyperthermia, and it would be applied to the peritoneal cavity body system value for the substance anti-neoplastic. And this, as the title tells you, and there's an acronym in the text box, this is for capturing the administration of hyperthermic intraperitoneal chemotherapy, HIPEC. And that's all I have. So thank you, and I'll turn it back over to Noelle.
Thank you, Rhonda. Does anyone have any questions for Rhonda? Just make sure you identify yourself.
You don't have to talk up.
Yeah, you don't have to talk up either. I think they'll hear you.
I guess I don't need to stand up. Hi, Rhonda. It's Linda Holtzman from Clarity Coding.
Hi, Linda.
Hi. I just wanted to ask as a general issue. I was particularly interested in the changes for coronary arteries, but it's not clear to me, anyway, when these would be used. So I don't object. What I'm asking is, going forward, if you're describing an addendum, or a change here, to give some examples. So, for example, on page 61, it talks about how the source is a coding clinic EAB and CMS internal review. So there must be certain procedures or certain devices that are associated with making this change. And it would be very useful if the description would say, not just generically that it enables capture of this detail to reinforce or augment, which is sort of axiomatic with supplement, but to say, for example, such and such procedure or such and such device that takes care of this or that diagnosis. So that way, when we're teaching the changes here, people can relate it to something very specific. And obviously, there's more that could be done, but just some examples. Then the reason why these are being done would be very helpful for those of us who do this kind of teaching. Thanks.
Okay, absolutely. Thanks, Linda.
Any other questions in the room? Okay, thanks, Rhonda.
Thank you.
Our last topic for the PCS codes is going to be administration of Imirel. And in the agenda and handouts packet, if you're following along, that is on page 57. Presenting remotely today will be Andrew Parker and Dr. Elise McCann, and they're from the Merck Corporation. The issue is there's currently no unique ICD-10 code, PCS code, to describe the administration of Imirel. There is a new technology application for 2020 for this particular drug, and then it is not FDA approved currently. So with that said, moderator, could you open the lines, please, for Andrew Parker or Dr. Elise McCann?
Hey, I'm looking for their line. Give me 1 second. Hi, Elise.
Right.
Hi, everyone.
Thank you very much, everyone. Good morning. My name is Andrew Parker. I'm a member of Merck's Global Market Access team. I'm joined here by my colleague, Dr. Ailish McCann. As was mentioned, we're here to talk to you today about imipenem relebactam, known as Imirel for short. As also mentioned, Merck has applied for NTAP for Imirel, and it's for that reason that we've requested the addition of new ICD-10 PCS codes to uniquely identify its administration. We believe this would accomplish two key things. Number one, of course, it would facilitate the actual recognition of NTAP on hospital inpatient claims should it ultimately be granted by CMS. And number two, it would facilitate the tracking of and research of Imirel use in the hospital inpatient setting. So with that very brief introduction, I'll go ahead and turn it over to Ailish to tell you a bit more about Imirel itself.
Thank you, Andrew. So I will be referring to the slides. I think, Noelle, are you controlling the slides in the room?
I am, yes. Thank you.
Thank you. So if we could move to slide 3, please. I think there might be a short delay, so let me know if you can see that in the room. Okay, now I can see. Thank you. So I just want to pick up where Andrew left off. He's mentioned that one of the reasons we're requesting these codes is to facilitate research on the use of Imirel in the inpatient setting. The reason we believe this to be important is we know that the CDC has identified the kind of infections that Imirel could be used to address as being immediate health concerns that necessitate monitoring and prevention activities. Specifically, the CDC designates carbapenem-resistant infections, especially carbapenem-resistant Enterobacteriaceae, as being urgent threats. And the urgent classification is a category that requires more monitoring and infection control activities, and also carries threats of high consequence because of significant risks identified across a number of areas, for instance, clinical and economic impact. So we would like to be able to detect Imirel usage and to understand its impact on some of these issues that have led to carbapenem-resistant infections being considered such an urgent threat. So if we can move to the slide 5, please. Thank you. So just to give some brief background about imipenem relebactam, first of all, reflecting on the need for a medicine such as this, beta-lactams, which comprise penicillins, cephalosporins, monobactams, and carbapenems, are the most commonly prescribed antimicrobials in use today. major cause of bacterial resistance to these important antimicrobials is the production of beta-lactamases. And there are 4 main classes of beta-lactamases, all of which function to engender resistance in slightly different ways. The administration of a beta-lactamase inhibitor in combination with a beta-lactam antibiotic can overcome this resistance. So next slide, please. So imipenem relebactam is an investigational fixed-dose combination of a beta-lactam antibiotic, imipenem, with a novel beta-lactamase inhibitor named relebactam. Now, the fixed-dose combination is administered intravenously every 6 hours, either peripherally or centrally. Relebactam is an inhibitor of 2 of those classes of beta-lactamases, class A and class C, and it's able to restore activity to imipenem in gram-negative bacteria which have become resistant to imipenem otherwise. We've shown this to be active in vitro against enterics that produce Klebsiella pneumoniae carbapenemases, or KPCs, also extended spectrum beta-lactamases, and it's further active in vitro against AMP-C producing Pseudomonas aeruginosa. Activity has been confirmed through both in vitro and in vivo animal models. Imipenem relebactam is currently under consideration by the FDA. We are seeking indication in patients aged caused by susceptible gram-negative microorganisms where limited or no alternative therapies are available, complicated urinary tract infections, including pyelonephritis, caused by susceptible gram-negative microorganisms where limited or no alternative therapies are available. Next slide, please. So Imirel has been studied in a number of clinical trials to date. We've explored clinical pharmacokinetics and safety across phase 1 to phase 3 clinical trials. Clinical efficacy and safety has been evaluated in 2 completed phase 2 clinical trials in both complicated intra-abdominal infection and complicated urinary tract infection. And clinical efficacy and safety has been evaluated in 1 completed phase 3 trial in imipenem non-susceptible infections, and I'll talk more on that in the next slide. There's also an ongoing phase 3 trial in hospital-acquired bacterial pneumonia and ventilator-associated bacterial pneumonia, as well as ongoing pediatric pharmacokinetic studies. Next slide, please. Briefly to the phase 3 trial, which has formed the basis of our registration with the FDA. This is called Restore IMI-1, and it was conducted in patients with imipenem non-susceptible infections. So a double-blind study design with 2-to-1 randomization, either into treatment group 1, which is imipenem relebactam given with placebo, or treatment group 2, which is colistin sulfate, which I'll refer to as colistin throughout the rest of the presentation, given with a background of imipenem. The enrolled patient population included patients with 1 of 3 different infection types, either HAP-VAP, CIAI, or CUTI. And patients had to have gram-negative infections that were imipenem non-susceptible, but colistin and imipenem relebactam susceptible. Included pathogens included Pseudomonas aeruginosa, Klebsiella species, and other Enterobacteriaceae. And the beta-lactamases detected in our enrolled patient population included AMP-C, extended spectrum beta-lactamases, Klebsiella pneumoniae carbapenemases, and also oxacillinase type 48. The treatment duration, Imirel was given for a minimum of 5 days for CIAI and CUTI, or 7 days for HAP-VAP, with a maximum otherwise approved by the sponsor. The endpoints for this trial, the primary endpoint was overall response, which did differently according to each of the infection types, either day 28 all-cause mortality for HAP-VAP, clinical response at day 28 for CIAI, or clinical and microbiological response at early follow-up visit for CUTI. We also assessed treatment-emergent nephrotoxicity in this trial. Next slide, please. So to very briefly summarize the results from Restore IMI-1 for the primary endpoint of favorable overall response, please note that this trial was not powered for statistical inference in this endpoint, but we showed the Imirel did meet the primary endpoint, and we observed overall response in 71.4% of patients in treatment group 1 and 70% of patients in treatment group 2. We also measured favorable clinical response, observing that in 71.4% of patients in treatment group 1 and 40% in treatment group 2. And also all-cause mortality through day 28, observed 9.5% of patients in treatment group 1 and 30% of patients in treatment group 2. We can go to the next slide, please. The figure that you're seeing here is just intended to show you that this observed differential in favorable clinical response was maintained across the different time points which it was measured in the trial. Next slide, please. So very briefly, for the adverse event summary, I'll draw people's attention, please, to the the bottom line in this table. We evaluated the number of subjects with treatment-emergent nephrotoxicity, and this endpoint was powered for statistical inference between the two arms. We observed nephrotoxicity in 10.3% of patients in treatment group 1 and 56.3% in treatment group 2. This was a statistically significant difference with a p-value of 0.002. Next slide, please. This is just to give some context on how nephrotoxicity was defined in this study. For those participants with normal baseline renal function, nephrotoxicity was defined as a doubling of serum creatinine or greater or equal to 50% reduction in creatinine clearance. And for patients with pre-existing renal dysfunction, which were enrolled into this trial, it was defined as an increase in serum creatinine or 20% reduction in creatinine clearance or a need for renal replacement therapy. And on the next and final slide, this is just to show that we've explored the nephrotoxicity outcome using different criteria. According to either the KD-IGO criteria or the Rifle criteria, we saw similar results across these different definitions. So with that, I'll conclude the presentation of Imirel background information, and thank you for your time today.
Okay, thank you, Dr. McCann. Is there anyone in the room who would have any questions, clinical questions for Dr. McCann? Okay, thank you. Hearing none, we'll move on to the coding options. I apologize, I don't have the coding options slide up, but I can get that to anyone who's interested. But we'll jump into option 2, create a new qualifier value U in Pentium, Celastatin, Relebactam in table 3E0. Administration applied to the fourth character values, peripheral vein and central vein, to identify intravenous infusion Imirel. So that would be the first option. And then the second option would be to create an X code for new technology. So for my usual folks, is there anyone in favor of option 2, nod head? Okay, option 3? Okay, thank you. Thank you. And Andrew and Dr. McCann, thank you very much for presenting to us today. And with that, I will turn it back over to Donna.
Good morning again, everyone. I'll apologize for my voice already because it's beginning to go on me. Our first topic for the diagnosis proposals this morning is the topic of sepsis. There's been a lot of discussion about the change in definitions for SIRS, sepsis, and severe sepsis. And so bringing this discussion and proposal, you do not have the information in the handouts yet. It was a a late posting or will be a late posting. So the PowerPoint presentation and the actual proposal with the background information will be added to the topic packet when it is updated. So you haven't seen this, but I think many of you are already quite familiar with the issues that have surrounded this particular topic since the release of the Sepsis 3 clinical criteria and definitions. So again, as many of you are aware, the new definitions were released in 2016, and you may recall from previous meetings that I had indicated that WHO, once those new criteria were released, began looking at what the criteria might, how it might impact ICD-10 as maintained by WHO, but also how it might inform the beta version of ICD-11. And of course, here in the US, there were questions coming into NCHS CDC, as well as the American Hospital Association's Coding Clinic Editorial Advisory Board on how coding would be impacted by this. New definitions, they're on the screen. I won't read through them all, but you can see them. But again, some important highlights here. One, SIRS is no longer the defining criteria of sepsis, as a patient can have a life-threatening condition without SIRS and a life-threatening, non-life-threatening condition with SIRS. There is inconsistent terminology in relation to sepsis, and it's created difficulties in coding it, but it's also produced inconsistent data. SIRS can result from a non-infectious origin, so there is a need to keep a code for that, and that will be one of the things that would be part of the proposal. And many patients can suffer from SIRS after surgery. SIRS is the body's normal response to an infection, so in itself is not indicative of anything. And lastly, the term severe sepsis is redundant. Now, I know there are going to be a lot of clinical questions related to the new definitions, and I am so happy to have in attendance at today's meeting Dr. Todd Dorman, who is our clinical expert on this. By way of background, and something just hit the floor. Dr. Dorman is board certified in internal medicine, anesthesiology, and critical care medicine. He's the Senior Associate Dean for Education Coordination and Associate Dean for Continuing Medical Education for Johns Hopkins School of Medicine. He is a professor and vice chair of anesthesiology and critical care medicine. And it's a very long introduction. It could be longer, but the other thing that I am happy to have him here representing is the work that he's done with the World Health Organization and the working group that was tasked with looking at the changes that may be relevant to ICD-10 and in the development of the codes in ICD-11. And he was part of that working group. So he is here, and so I think if there are clinical questions before we start thinking about the coding options, I'd like to invite Dr. Dorman to he can either stay in his chair since he's mic'd over there, or actually come up to the podium to handle any clinical questions. And so I'll open the floor for questions. Particularly would like to hear the experience of those who are kind of working in the area and see where they believe there are problems that need to be fixed in ICD-10 CM, of course, upon which 10 CM is based on the WHO version. We had actually hoped that WHO would have modified the codes in ICD-10. However, they were not able to do so before actually sunsetting the updating process for ICD-10. WHO is no longer maintaining 10 and, of course, is now totally focusing on ICD-11. The structure in ICD-11 relative to the SIRS, sepsis, and severe sepsis codes is very different. There is a structural change. However, that structural change cannot be accommodated in ICD-10. So we will be looking to harmonize as much as we can what we do in 10 cm, but we do have some guidance and some options that WHO was initially exploring before the decision was made to cease the updating process for ICD-10. But let me stop there. Are there any clinical questions that people would like to ask? Yes, please identify yourself.
Dr. Jim Kennedy, could you please describe what criteria today is definitional, the best definition for sepsis or severe sepsis or septic shock in the adult, pediatric, and neonatal population?
And I will turn to my colleague, Dr. Dorman, for that response. Thank you.
So I'll try to address that as best I can. I think we need to be clear that the definition and the clinical criteria are two distinct functionalities. The definition is a presumed infection with a dysregulated host response and organ dysfunction. In 3.0, a definition that has been pretty close to universally accepted in adult. The pediatric groups that are working on determining the best clinical criteria have accepted that core definition, and the WHO definition of sepsis, maternal sepsis and neonatal sepsis has also accepted that as a definition. The work of Sepsis 3.0 that provided information relative to clinical criteria is very clear that the exact clinical criteria still need to be worked through. They propose several clinical criteria, SOFA or QSOFA, depending upon the location of the patient, in adults, not in pediatric or neonatal. And they propose those based upon retrospective data analysis, and were very clear that those then needed to be prospectively tested. There have been numerous publications since then, some of which support those, some of which have not supported those as precise clinical criteria. But what is clear from the work that was done is that somewhere around 13 to 15% of patients with SIRS do not have sepsis and are not infected, and somewhere around 13 to 15% of patients who have sepsis, who are infected, do not have SIRS. So SIRS were inadequate as the clinical criteria. Does that help?
Yes, sir.
Are there any other clinical questions? Okay, Tracy, advance to the last slide. Okay, so during the discussions with WHO and other countries who are actually part of the working group, looking at ICD-10, one of the options that they had seriously considered was deleting the entire category of R65. And so all of the expansions that we have under that, the R65-1, the R65-2, the SIRS, with or without organ dysfunction, the severe sepsis, all of those codes would be deactivated. They would not be reused at any point in the future, and any of the NOS concepts would be sent to other existing codes, and that's what we're still exploring and how best to do that. The challenge will be, and why you don't have a full proposal at this point to consider, is WHO, during the 4.5-year code set freeze that we had for ICD-10-CM, WHO was still making incremental changes related to septicemia, sepsis, severe sepsis in ICD-10, which we could not incorporate because we were on a freeze. So now we're taking a step back, looking at all the incremental changes that WHO did, and we're now also waiting for them to post their final updates to ICD-10, which are due out within the next month or two, to see what other changes they may have undertaken as part of the final update. So again, we want to benefit from the work that was already done by WHO, even though they did not make wholesale structural changes to ICD-10. We do want to mirror what they have done as we consider how to make modifications in ICD-10-CM, because obviously 10-CM is going to be with us for a while, having just implemented ICD-10, CM, and PCS October 1 of 2015. So this is an important issue, something that cannot go unaddressed and certainly cannot wait until any future discussions and decisions are made regarding ICD-11. And I want to thank Dr. Dorman in advance for knowing that he will be talking to me quite a bit as we gather the rest of the information to complete this. Again, we'll post a draft of what we are currently thinking, but we need to be informed by the additional work that WHO undertook before sunsetting ICD-10. So you will definitely see this as a topic at the September meeting, but we wanted to bring it to your attention now, but also to let you know that we have heard your comments and concerns and some of the challenges that have been brought on by trying to maneuver between new definitions, interchangeable terminology that may not be interchangeable, and some of the other confusions that have arisen since Sepsis 3 criteria were introduced. And again, we're not going to be able to address all of the concerns, because I wanted to say that as well, because somebody else had mentioned it to me. The things that are related to audit and which criteria are being used, the R-word reimbursement that we do not discuss in this forum, those are going to be aspects that would be outside of what we attempt to do in modifying 10CM. But again, we have to remain within the structure and conventions that are set in 10. And while we understand things are much better in 11, they were able to make those wholesale changes in 11 that we are not going to be able to do. And WHO wasn't able to accomplish it either. So you will see this again, but we wanted to bring this to you because I know I have mentioned to you in the past that we were going to be working on this. And we thought this would be a good opportunity to let you know that we are working on it, but we have some other challenges. And again, I can't thank Dr. Dorman enough for past good counsel and future good counsel. Introduce yourself, please.
Sue Bowman, American Health Information Management Association. I was just wondering if you're looking for any comments or suggestions by the May 10th deadline for this meeting, or this is just a general overview and you're anticipating that the greater discussion and comment will occur with the September. Just wasn't sure what you wanted us to do now.
Having comments from people by May 10 would be excellent because it would help inform the work so that we're kind of like not doing incremental steps, much like what WHO had to do when they were considering changes to ICD-10, because we would like to bring a more fully developed proposal to the meeting. And again, we will post our current draft so that you can consider that when you're formulating your comments. And if you've written to us before, no harm. Please write to us again because you'll have something in front of you to react to. And so that will help, I think. So yes, May 10th would be excellent because that would give us time to consider and work with others to try to figure out how best to accommodate this. Any other comments or questions?
I don't know if you noticed, but Dr. Scott Maneker walked in and was standing kind of in the doorway, and I thought he'd wanted to comment on that, but not to put you on the spot, sorry.
Now that you have.
Well, thanks. I really got here late, and I didn't have the chance to appreciate Todd's presentation and the earlier comments, but I would say that both the Thoracic Society and the chest physicians would be highly supportive of trying to find a way to integrate the Sepsis 3 definitions with the existing ICD-10 so that we can continue both clinical and research endeavors.
Good, thank you, Dr. Maneker. I didn't see you back there.
Traffic held me up, as you might predict.
I figured the flag was in the way.
It was. I see the flag. Okay, hearing no additional. Introduce yourself, please.
Jeff Linzer, American Academy of Pediatrics. While we appreciate the adult focus of SEP3, we would caution against using those definitions to define the code set, since they are not necessarily applicable into our patient population.
Thank you, Dr. Lindsay.
Again, I would stress that the definition is different than the clinical criteria, and the definition is applicable. It's the clinical criteria that are still being addressed, academically, scientifically, evidence-based.
And just to jump in and comment on this, as I've looked at it some too, I do want to say we aren't intending to try to put the clinical criteria into the ICD. We do not intend to have to ask coders to make the diagnosis of sepsis based on what the documentation shows and what the doctor said. We want the coders to be able to go and look and see if the doctor diagnosed sepsis, not try to help the doctor make that diagnosis. That is, of course, always the way we try to apply things in ICD, but just to be clear, we're not intending to put the clinical criteria into the ICD. We just want to have certainty that the documentation will support the coding, but we always are going to be intending to let the doctor make the diagnosis, or the healthcare provider, if you prefer. As God intended, thank you. Okay. Says softly here.
Okay.
When will these changes?
Please introduce yourself again.
When will these changes be tentatively implemented for, would that be for fiscal year 2020 or 2021?
Proposals presented in March and September of 2019 or for consideration for October 1, 2020.
Okay.
Fiscal year 2021, of course. Yes, that's your Neonatal way.
Okay, seeing no other raised hands or raised eyebrows, I will now turn the presentations over to Cheryl Bullock, who will introduce the next 5 topics. Cheryl?
Good morning, everyone. There is one seat over there, Dad. You sure?
I'm good. I've
There's
been
one in
driving
the
for a
corner.
couple hours, thanks, so standing feels good.
Oh, and there's a couple more. Someone's reserving one. You good?
Thank you.
All right, good morning again. I do have the opportunity of presenting the next several proposals, and they have been submitted by the American Academy of Pediatrics, and I have the honor of having Dr. Jeff Linzer and Dr. Edward Leike, both members of the American Academy of Pediatrics, Coding and Coding Nomenclature, and representative to ICD-10. So our physicians will do the clinical presentations, and then I will do the coding pieces of it. So the first topic will be the elevated liver enzymes found on page 22 of your topic packet.
Good morning.
Good morning.
First slide, that part of the slide. Next slide. So, as you can see here, this example, you have a healthy 12-year-old who's having routine laboratory tests. And the tests come back showing elevation of certain liver enzymes and tissue enzymes. And because of this, without any other symptoms, additional testing is indicated. Okay. So AST and ALT, you can see the technical names are liver enzymes, and LDH is a tissue enzyme. Second clinical situation, you have a 4-year-old child who was appropriately restrained in a vehicle, comes into a trauma center and has routine laboratory tests as part of the trauma evaluation, does not have any other clinical findings such as contusions on the abdomen. Because the AST and ALT are elevated, and because the literature has demonstrated that elevations of a certain point are associated with interabdominal injuries, the child now has a CT scan with ID contrast. The test comes back negative, not showing any interabdominal injury, and the child's discharged home. In this particular case, to use a Z code that said, hey, we saw this kid for a transport accident without any findings, would not justify the resource utilization, especially the risk of IV contrast abdominal CT. Next slide. Next slide, thank you. Okay, so again, we need to be able to demonstrate resource utilization and why these patients are being subjected to additional testing. Next slide. Okay. So asymptomatic patients who have these elevations, what could it mean? Well, if the liver enzymes are elevated, they could have an occult neoplasia or occult infection. For the LDH, not only could it be an occult neoplasia or infection, but it could be occult skeletal or cardiac muscle injury, and it could be signs of anemia. Next slide. So we have proposed an expansion at the nonspecific elevation of transaminases and LDH to separate out these diagnosis codes because of the specificity that shows resource utilization. And that's briefly what the new codes look like. That should be the last slide. Any questions?
Any questions for Dr. Lynn?
Sir.
Why was alkaline phosphatase or GGTP not included in your proposals?
I'm sorry, say again, please.
Why was alkaline phosphatase or GGTP not included in your proposals since those are liver enzymes?
Because these have been the principal enzymes that we have looked at in the pediatric population. There can be an elevation of the GGT that could be indicative of a liver or a gallbladder problem, but that is not as common as the elevations in these, and that's why our proposal was limited to these two areas.
For Dr. Lynn.
Dr. Lynn.
Linda Holtzman, Clarity Cody. Do I understand correctly that different types of tests will be done depending on whether it's ALT, AST versus LDH?
Depending on the clinical situation, yes.
Okay, thank you.
Any other questions?
Okay, and just to reiterate, the proposed new codes, again, that are found on page 23 of your topic packet. A category R74, abnormal serum enzyme levels. 2 new codes are being proposed.
I'm trying to get to it.
Okay, sorry.
Go ahead, but there's a delay.
Yeah.
Now, while we're waiting, can I ask Dr. Lynch another question?
Sure. Dr. Lynch? He said no.
Does it happen that both can be elevated?
Of the AST and ALT?
Yeah.
Yeah, they usually will tend to be. Can one be and the other not? Yes, but they tend to both.
The only reason I ask is because we got into some discussion yesterday about the volume of codes and running into trouble, running out of space to submit. So I wonder if it's worthwhile to have an additional code for both. I mean, obviously we can code R7401 and R7402, but perhaps there should be an R7403 for elevated enzymes of all of them.
Right. But we didn't propose that each one had its own identifier. We essentially separated out liver transaminases and LDH from the total grouping right now.
Right,
So in essence, other liver transaminases technically could be coded under the R7401 just because it's not listed as an inclusion term.
No, actually where I was going was, do the liver enzymes, are they typically elevated at the same time that the tissue enzymes?
No.
Okay, that was my question, thank you.
Okay, no, that wasn't clear. But,
Sorry.
Yeah, no.
Yes, sir.
Dr. Joan Kennedy, is not the AST also found in muscle? And should this be labeled as a liver transaminase, given that AST, can be elevated with muscle injury as well as liver injury?
So it's commonly on the hepatic function panel and in part of the comprehensive metabolic panel looking at liver. So our goal was to look at these generally as liver related and the LDH as tissue related.
Okay. Continue with the code proposals. At R74.0, again, nonspecific elevation of levels of transaminase and lactic acid dehydrogenase. 2 new codes are being proposed at R74.01 which is abnormal levels of liver transaminase with inclusion terms of abnormal level of ALT and abnormal level of AST, and an additional new code R74.02, elevation of levels of lactic acid dehydrogenase, LDH. Are there any more questions regarding the proposed codes? Yes, ma'am.
Okay, at Nellie Leon, Chisane American Hospital Association. So at the R7401, it says abnormal levels. Is it intended for abnormally high as well as abnormally low? Because the subcategory title at the 0.0 seems to indicate it's only for elevated. And so wondering if you deliberately wanted to keep it generic because the O2 is elevation of levels.
So the original proposal was elevated, and NCHS made the change, so you need to ask NCHS.
I don't know if that's Dr. Lenzer. Throw me under the bus. We're going to go back to Dr. Lenzer and then ask to clarify. How about that? I see what you're seeing, because one is the abnormal, abnormal level. So whether it's an increase or a decrease, is that the specificity that you're trying to get to, that you're saying?
Yeah, because it doesn't seem to line up with the R74.0, which is at the subcategory level, and these are indented underneath. The other thing that kind of confused me is I didn't know clinically, and so the ALT normally would be low, it's what some articles said, but I also found some studies that seem to be thinking that a decrease in ALT could be associated with a risk of mortality. And so that's what made me think that you could end up with, abnormal could be high or low. And so I didn't know if you wanted to make that distinction or not.
So that's a clinical one.
Well, but yeah.
However,
Because, but also because if you wanted to identify low, then maybe it shouldn't be in that same family.
Okay. We'll tweak it.
Or you would need to change.
Or change the title.
To all be elevation or all be abnormal.
All be
Gotcha.
abnormal. Codes underneath are consistent with the
Yeah.
title of the subcategory.
Thank you.
So it's coding.
Any other questions or comments for this proposal? Okay, not hearing any. We'll move on to the next proposal, which is the immunodeficiency status. And Dr. Lenzer will take the clinical portion of this presentation. We got
All right, next slide, please. All right. So, 10-year-old child had a splenectomy due to a splenic laceration. Okay. There are about 22,000 splenectomies per year of all ages in the United States related to trauma. You have a child. This child's now at risk for infections by what are called encapsulated organisms and may require daily doses of antibiotics as prophylaxis to decrease the risk of infection from the listed organisms. There's also an increased risk of pneumonia, meningitis, and septicemia, or septis, or severe sepsis, or SEERS. Next slide. You have a 12-year-old with severe persistent asthma who requires daily oral steroids to keep the asthma under control. Okay. The effect on the child's immune system is expected from the steroid. It's not an adverse effect, it's an expected effect. That's why the child is receiving this particular medication. Next slide. So the terms immunocompromised, immunodeficient, and immunosuppressed clinically essentially are the same thing. So the physician or the clinician could write any of those terms and mean the exact same thing. And this can be due to an underlying condition such as HIV. This can be due to an underlying condition because of acquired absence of a spleen. This could be due to the medications, as I gave the example of steroids, or it could be due to an external cause such as radiation therapy for a neoplasia. Next slide, please. So the difficulty is there's a single code right now that just says you're immunocompromised. And it does not provide enough detail and information as to why the patient is immunocompromised. And this is a fairly significant issue in tracking this particular group of patients. We have discussed this proposal a couple of times before, and we have taken the various comments into consideration and provide this revision. And I'll let Cheryl go through the code sets.
Okay. Are there any clinical questions right now for Dr. Linzer? Okay. And as Dr. Linzer mentioned, yes, this proposal was presented back in March 2017 and March 2018. So hopefully this revision, we've revamped it, addressing all of the issues that were presented in the comments as well. So,
What page are we on?
29.
All right.
Okay. So at category D84, other immunodeficiencies, a new code is being proposed at D84.81, immunodeficiency due to conditions classified elsewhere, with an instruction note of code first underlying condition, if known, such as acquired abscess of spleen, and there are others such as examples given under that instructional note. There's also a proposed excludes one note that includes combined immunodeficiencies, common variable immunodeficiency, lymphocytic function antigen defect. New subcategory at D84.82, immunodeficiency due to drugs and external causes. A new code, D84.821, immunodeficiency due to drugs, with an excludes two note of adverse effect of drug T36 to T50 with the fifth and sixth character of 5. An instruction note is also being proposed to code also drug or medication such as long-term current drug therapy. A proposed new code, D84.822, immunodeficiency due to external causes, again with an instructional note to code also external cause such as encounter for antineoplastic radiation therapy, Z51.0. New code, D84.89, other immunodeficiencies is also being proposed. And at the existing code, D84.9, immunodeficiency unspecified, it is being proposed that 3 additional inclusion terms be added: immunocompromised NOS, immunodeficient NOS, and immunosuppressed NOS. Also, you would note that at the chapter 19, at the chapter level, the section under T36 to T50, we're adding to the existing exclusion 2 note for immunodeficiency due to drugs, D84.821. Do we have any questions about the coding proposal? Yes, ma'am.
Sue Bowman with the American Health Information Management Association. I'm somewhat confused by some of the instructional notes and some of the inconsistencies in the instructional notes.
Okay.
First of all, this is kind of a more minor one, but under D84.81, it says code for its underlying condition if known, but the code is immunodeficiency due to conditions classified elsewhere. It seems like to get to that code to begin with, you'd sort of have to know what it is, unless he puts down immunodeficiency due to some condition. I'm not going to tell you what it is.
Okay.
Otherwise, it seems like it would be more of the unspecified immunodeficiency unless you knew what it was.
Okay.
I don't know how often this would be the principal diagnosis, but it also suggests that if it's due to acquired absence of spleen, you're now going to have Z90.81 as the principal diagnosis, which seems a little concerning. So that's one thing. Under D84.82, 1, immunodeficiency due to drugs, it says excludes 2 adverse effect of drug, but in most places it's I would think it would be a use additional code note because it's a condition caused by a drug. So I'm not sure why it's an excludes two. And on the next page, when it talks about the code, also drug or medication such as encounter for anti-neoplastic chemotherapy and immunotherapy, that's not a code for the drug, that's a code for the reason, it's a reason for encounter code. So that one didn't make any sense to me whatsoever. And the same with the one under D84.822.
Okay. So I can answer the code also issue, the excludes two on the drugs. They are not adverse effects, they're expected effects. So that's why you would not code also those T codes for adverse effect for the drugs.
So the excludes two is intended to mean if they have, I don't know what it means then. So if they have some other adverse effect of the drug, you can code it two, which I would think you would be able to do even if you didn't have an excludes two note.
That would be the intent. It would also mean that if there was another drug other than what you were giving, so for example, the patient was on steroids and antibiotic and had an immuno issue due to the antibiotic, you'd be able to code the adverse effect from the antibiotic under the excludes two.
I don't think that's clear because I interpret this excludes two note meaning if you have immunodeficiency that's an adverse effect of a drug, you code it to this other code, and that didn't make any sense to me at all because it sounded like it was talking about the same condition.
Okay. I see that we need to definitely work on the instructions, but I think we have the coding, because I know previous comments was a lot about the repetitiveness of some of the codes and the overlap, et cetera. So it appears now we need to work on the instruction on those. Yes.
Clean those up a bit.
Yeah, Nellie Leon, she said, in addition to the instructional notes that Sue just mentioned, there are two of these code also notes, one at the .821 and the other one at .822 that I don't think you want in there. One of them is the encounter for anti-neoplastic chemotherapy and immunotherapy, and the other one to anti-neoplastic radiation therapy, the Z51 codes, because that goes against long-standing guidelines that have been there for a very long time. So I don't think you really intended to change the sequencing for that. I mean, it's very specific that if someone is coming in solely for radiation or for chemotherapy, that is your principal diagnosis. So I think that this kind of locks you out of that option.
Well, and I think it's misusing what those codes are for.
Right.
They're reason for encounter codes. They're not intended to describe the underlying drug that's related to the
Or
drug.
external cost,
Right,
which is
right,
the other
right.
one
They're not
that
an
the
external
22
cost.
says external cost, so it's not an external cost code.
So you'd suggest using an external cause code instead?
Yeah, if that's what's causing the immunodeficiency, yes.
Okay, well, yes, sir.
Dr. Joan Kennedy, I have a little trouble with the excludes one note for D84.81. Many of these, yes, there are children who have these conditions and they're well managed by their pediatricians, but then they get a splenectomy or they become diabetic or they have to be treated with steroids for other reasons. And the only way then to report both of the codes in this population would require explicit documentation in the record that the two conditions are not related to each other, because that's the exclusion that's been written in the guidelines. So it's, I believe that should be an excludes two note, which would allow the co-reporting of both of these conditions when present, without the additional documentation burden. I also believe that B20 or C21, should be added to this, since I would think that in immunocompromised state would be inherent to having HIV.
Well, there excludes ones because they're already titled immunodeficiencies. So it would be repetitive to say an immunodeficiency is immunodeficient.
My concern regards the documentation burden of being able to report both conditions when present.
Well, it appears that we do need to work, we will work on and revisit our instructional notes for this proposal. And I do look forward to your comments in writing so that we can make sure we address all issues, okay? Are there any other comments or questions regarding this proposal? Not hearing any. The next proposal is sickle cell disease. Dr. Linzer.
You may be wondering why I asked you all here today. Okay, so sickle cell is an inherited condition where you get bad hemoglobin, one from each parent. And there are a variety of different flavors of sickle cell, from the homozygous SS, where you inherit the S hemoglobin from both parents, all the way down to SD and SE, which are less common and less severe. Next slide, please. 50% of children with SS disease will have at least one episode of acute chest syndrome in their lifetime. 30% will have splenic sequestration of all sickle cell patients. 1 out of 3 males with sickle cell disease will suffer from priapism in their lifetime. 24% of children with sickle cell will have a stroke before the age of 45, and 11% of children will have a silent ischemic stroke before the age of 14, and 20% will develop cholelithiasis. Next slide. Currently, there are 3 codes for sickle cell: vaso-occlusive crisis, NOS, or unspecified, with acute chest, and with splenic sequestration. So obviously, there is no good way of capturing these other conditions with the current available codes, because you're saying vaso-occlusive crisis unspecified, and clearly there's something else going on. Next slide. Oh, back. Sorry. So what we're trying to do is to expand the code set so it better picks up these other conditions. Cheryl?
Okay, the proposed codes can be found on page, I think it is 51 in your topic packet for the sickle cell disease. So this again is a repeat. This proposal was presented September 2016, March 2018, and again we've attempted to revamp and address the issues that were brought forth and based on the previous proposal. So proposed code modifications. At D57, at code D57.0, HB sickle cell with crisis, is being proposed to revise the inclusion term of sickle cell disease NOS with crisis. So we're deleting the NOS. At code D5700, at D5700, 2 new inclusion terms are being proposed, which is the HB sickle cell disease with crisis NOS and the HB sickle cell disease with vaso-occlusive pain NOS. There's a proposed new code at D57.03, HB sickle cell disease with cerebral vascular involvement, with an instructional note of code also, if applicable, cerebral infarction. There's a new code being proposed at D57.09, HB sickle cell disease with crisis with other specified complication, with an instructional note that says called also manifestation such as cholelithiasis, fever presenting with conditions classified elsewhere. At D57.2, there's a new subcategory being proposed at D57.21, which is sickle cell HBC disease with crisis, where a new code is being proposed at D57.213, sickle cell HBC disease with cerebral vascular involvement, with an instructional note of code also, if applicable, the cerebral infarction. There's a new code at D57, new proposed code at D57.218, sickle cell HBC disease with crisis with other specified complication, with a code also manifestation instructional note. And at code D57.219, sickle cell HBC HBC disease with crisis unspecified is being proposed to add an additional inclusion term of sickle cell HBC disease with crisis and vaso-occlusive pain, NOS. At code D57.41, sickle cell thalassemia with crisis, a new code is being proposed at the D57.413, sickle cell HBC disease with cerebral vascular involvement.
That's actually sickle cell thalassemia. It was a cut and paste, and it was just one of those a little miscut and paste.
Thank you.
That will be corrected.
That's all we have. We're good. Okay, and thank you, David. So we'll fix that in the appropriate code title. Then at new code D57.418, sickle cell thalassemia with crisis with other specified complication with an instructional note to code also manifestations such as, and examples are given. At code D57.419, sickle cell thalassemia with crisis unspecified, there is a proposed new inclusion term of sickle cell thalassemia with crisis with vaso-occlusive pain. For code D57.81, other sickle cell disorders with crisis, a new code D57.813, other sickle cell disorders with cerebral vascular involvement, with an instructional code also note. New code D57.818, other sickle cell disorders with crisis with other specified complication, with instructional note, code also manifestations such as cholelithiasis and priapism. Any clinical or coding questions for this proposal? Yes, ma'am.
Sue Bowman with AHEMA. Must be my day for instructional notes.
Okay.
Under the codes that have the code also manifestations, and there's several of them, I'm not going to list them all. At least, code also means there's no inherent sequencing. However, for the second two, not the cholelithiasis, but the other two, the fever and priapism, there are notes of that code saying that the underlying condition must be coded first. So this would really be a use additional code note for those two in order to be consistent with the note of the other code.
Any other questions or comments?
Teresa Organic Intelligent Medical Objects. Just a tweak on the codes. D5709 is with other specified complication, and then the codes later on, D57219 is with crisis unspecified, and I think the 218, that the code above should be D5708 for with other specified complication instead of a 9.
Can you repeat that?
So D5709 is with other specified complication, and when you go down, D57219 is unspecified, but 218 is with other specified class complication. So the other specified complication should end in 8, not 9. I think the D5709 should be D5709.
Doesn't that have to do with how many characters out it is?
Yes. You are correct, Dr. Lanzer, yes. And that is something we've had a number of questions about when we were determining what characters to use when. At the 4th character, it's different than at the 5th character. The 4th and the 6th character are the same, with 8 and 9 being other and unspecified respectively. But at the 5th character, the other is the 9 and the unspecified is the 0. So it's handled differently at different levels.
But I'll definitely go back and verify, but I think this is correct.
Yeah. But that is the way it is throughout the classification, so we try to keep doing it that way since we've done it that way before. I think this was originally intended so we wouldn't get the same 3 characters in a row as much, but whether that's necessarily always helpful isn't always clear, but in any case, that's the way it's been doing. We've been doing it and are going to continue to do it.
Thank you.
But thanks, yeah.
Any other comments, questions? Again, please submit your comments in writing so we can address all the outstanding issues. And I see the instructional notes that do need clarification. So our next AEP proposal is suspected foreign body ingestion.
Okay, next slide. Okay, so I principally do pediatric emergency medicine, and these are examples of patients who walk into the department quite frequently. I think the 2-year-old swallowed a coin. I think my 5-year-old put a bead up his little brother's nose. I think she stepped on a piece of glass last week. So what's in common is they're concerned that there's a foreign body somewhere. Next slide, please. And what will happen is, so what's the resource? So you're examining the child, you may be doing radiographic imaging on the child, you may be doing ultrasound imaging on the child, trying to see if there's something there, and there's nothing there. And there's no good way with the current codes, as you can see on the slide, to explain why you did what you did. It doesn't give you any information. So, next slide. So essentially, we're proposing codes to indicate whether it's something ingested, so a swallowed coin, for example, something aspirated, so they breathed in their chewing gum, or injected or inserted. So it would be inserted in an ear, it would be inserted in a nose, it would be something, a piece of glass you might have stepped on. And that's the code proposal. And Cheryl, it's your turn.
At category, proposed codes at category Z03.
Sure, sorry, what page are we on?
62. Starting on 62. So at category Z03, encounter for medical observation for suspected diseases and conditions ruled out, a new subcategory is being proposed. Encounter Z0382, encounter for observation for suspected foreign body ruled out. There are two, and excludes one notes that indicate, excludes one, retained foreign body in the eyelid, retained foreign body in soft tissue. The proposed excludes two notes, include confirmed foreign body ingestion or aspiration, which includes foreign body in eye, foreign body in ear, foreign body in respiratory tract, and alimentary tract. The new codes that are being proposed is Z03821, encounter for observation of suspected ingestion foreign body ruled out, 822, encounter for observation for suspected aspirated inhaled foreign body ruled out, and Z03823, encounter for observation for suspected inserted or injected foreign body ruled out. And there are three proposed inclusion terms: encounter for observation for suspected or inserted, inserted, injected foreign body in the skin ruled out, in the eye ruled out, and in the orifice ruled out. Any clinical or coding questions regarding this proposal?
Sue Bowman from HEMA. I'm just wondering if we need an other. Are there any orifices or places that we You can always come up with some new place that doesn't fall into one of these categories.
Yeah, not that I can think of. You put it
I'm
in
sure
your
you've seen them all.
Any other comments? Yes, ma'am.
I just wanted to comment that I heartily support this, and I wish that these codes had been available 22 years ago when my son kept sticking stuff up his nose. But only sometimes.
Thank you. Okay, not hearing any. I do have one more proposal. Dr. Likey Stern, Dr. Linzer. Thank you very much.
Come on up.
And this is the neonatal cerebral infarction. Tag.
Thank you. Next slide. So I'm a neonatologist at Indiana University and often take care of babies that come in with seizures or an abnormal neurologic exam, and we turn out to have a cerebral infarction in the infant. So it most commonly presents as a neonate with seizures or an abnormal neurologic exam. The incidence of this disorder, injury, is thought to be somewhere between 1 in 2,500 and 1 in 5,000, although we're finding more and more of these infants as our neonatal imaging gets more refined. And the etiology and timing of these is usually unclear, although it's likely that many of them occur in utero before the baby's actually born. Next slide. So how would this be documented in the chart? On the left is just a cut from an MRI on a baby that had this injury with, you can see, a large amount of neurologic tissue loss on the left side. And so I think for the coders, from the coder standpoint, there's two places this would be documented. First of all, the radiologist or neuroradiologist report, and this is verbatim from the report on that particular MRI. With the radiologist documenting that it was an infarct involving the left frontal parietal lobes and corresponding to the left MCA vascular territory. The other place you'd find documentation is from either the attending neonatologist or attending neurologist, and in this particular case, the neurologist documented clearly that it was a left middle cerebral artery stroke, but coded it as P91.0, which is just cerebral ischemia. And this is really not ischemia, this is an infarction. So at present, there's no code that exists to accurately code this particular injury. Next. So why do we need this new code? As I said, it's currently often coded as simply cerebral ischemia. It's occasionally, although not usually, coded as an adult cerebral infarction would be coded in the I-60 through I-69. Or it's often just coded based on the signs and symptoms that the baby exhibits, such as seizures or hypotonia. P91.0 fails to show the severity of the condition because you can have ischemia without an infarction. And the I-60 through 69 fail to distinguish from strokes that are occurring in older patients. And for these babies, there's really a need for this code for tracking purposes, but also for referring them for services which they need, such as first steps, early intervention programs. Next slide. So that's your part.
Okay, the proposed code modifications, you may recall this topic was presented at the September 2018 CNN meeting, and it received general support. However, we have previously presented at expanding at the P9188. So we have revised that we're expanding now at the P91.82.
37, 38.
So now we're proposing to expand this at the P91.82, neonatal cerebral infarction. with the inclusion terms of neonatal stroke, perinatal arterial ischemic stroke, and perinatal cerebral infarction. There are two proposed excludes notes. There's an excludes one of cerebral infarction, and at the I-63, and excludes two intracranial hemorrhage of newborn at the P92. The code proposed indicate laterality because he indicated that that was significant. P91, 821, neonatal cerebral infarction of the right, 822, left, 823, bilateral, and 829, unspecified site. We've added in this proposal at category I-63, we've added an excludes one note for the neonatal cerebral infarction, P91.82 which is one of the proposed new codes. And also we've added, it is being proposed to add a excludes one note at the P91.0 neonatal cerebral ischemia for an excludes one of neonatal cerebral infarction, P91.82. Are there any clinical or coding questions for Dr. Likey or myself? Yes, ma'am.
Sue Bowman from AHEMA. What is the right, left, and so on side referring to? The side of the brain that had the stroke, or the side of the body that's affected? Or I think it's not really clear what the side means.
I think it should be the side of the brain where the stroke occurs. Okay. So maybe that needs
right
to be
side
clarified.
brain. Okay. We can tweak that. Any other comments or questions? Okay. Yes, sir.
Kennedy, CDIMD. It's important to note brain stem or brain stem strokes or cerebellar strokes because I don't think that most people think of the cerebellum as being right or left, and of course brain stem strokes or spinal strokes, spinal cord strokes, can occur, and spinal cord strokes even in adults. It's a challenging subject. Can you maybe speak to those areas of the central nervous system?
Well, those would be extremely rare in the perinatal period. I don't believe in 35 years I've ever seen, certainly never seen a spinal cord stroke. There are cerebellar hemorrhages that occur, but I've never seen a cerebellar stroke. So.
Okay. We see them in adults.
Right.
All right. Thank you. Ms. Donna. I'm turning it over to you.
Okay, so our next two topics actually fit under the umbrella of a much larger topic, and that is social determinants of health. And so we have two proposals, one from Blue Cross Blue Shield Vermont with joint collaboration with Yale School of Nursing, and then we have a larger proposal from United Healthcare, and we actually have representatives here today to address that proposal. The materials were posted on the website yesterday afternoon. They will be taken up and officially incorporated into Part 2, but to make sure everybody could see that something else had been posted, we left it outside of Part 2 so that you could actually find it quite easily. So with that, I'd like to bring up our speaker, Dr. Ephraim Castillo, who is the Chief Medical Officer from United Healthcare, to get us started, and then I'll walk through the topic package. Dr. Castillo.
Thank you, everybody. Do I have an hour, or what did you say? I want to make sure I use all my time. So, hi, I'm Ephraim Castillo. I'm the Chief Medical Officer for Medicare and Retirement at United Healthcare. And this is something that we've been working on. Thank you all for having me. I practiced for many years, but have moved over to the healthcare delivery side over the last probably 10 years or so. one of the things that we really want to discuss with you guys is, I think this is, so I've listened this morning, I find it very interesting. But I think what we're trying to develop and explore is how can, as a healthcare system, we continue to improve outcomes. And that's one of the reasons we're really focusing on social determinants of health. We think we can improve outcomes while working within the provider workflow that supports improved interventions, because now we have the information. Now we know what's happening. Now we can actually do something that perhaps we hadn't thought we could do before. We could use it for avenues for research and understanding and ways to really change lives. So that was my kind of elevator speech, if you will. So now I'm going to just tell you, so just to level set, so could you go to the next one? So what are social determinants of health? Okay, so I think we kind of know about them. What are the barriers to care, if you will? So this is a representation of all the things that could be considered and are considered as barriers to care. So if you think about things like not having a job, not having food, not having transportation, being in an unsafe environment, being in an environment that is not conducive to health. So we all recognize that those things occur and are very significant in improving or not improving to the detriment of people's lives. We all know that. And I think what we have struggled with, and I struggled with for many years, is what do I do about it? How can I actually do something as the physician in the office? What available resources are there at scale that I could access to make something happen? So could you go to the next one, please? So we know this data. We know that 20% of health outcomes are attributed to clinical care, but 80% of them are contributed to the environment, the socioeconomic, what's happening around them when they get out of the office, when they don't take their medicines, as an example. We know that the life expectancy is 15 years different between advantaged and disadvantaged Americans. 15 years. We know 162,000 people die annually due to low social support. 162,000 people. Now, 85% of physicians report that unmet social needs leads to poor health outcomes, and only 20% of them are confident they can do something about it. Now, I remember when I was in practice, I would always get, and I'll be very transparent, I'd get frustrated because you'd have the same folks coming in all the time, and things weren't getting better. Things weren't necessarily changing. And how could I address that? How could I utilize current resources that exist in the community today in a way that I could do at scale? How can I understand my patient population? Even though my coding was accurate, my patient population was sicker. I don't know if you guys have heard that. I hear it all the time. My patient population is sicker, and I say, well, you have the same number of codes. And they say, well, they're socioeconomically disadvantaged. Well, there's no way today for me to understand the severity of that. Okay, we have some of those codes, but when we start to get granular and understand what's happening, it becomes quite difficult. Okay? You're doing very good. Thank you. By the way, so we propose improving the system to address these needs and understanding what we can do. So this is just, the advisory board has put out kind of the how, the why we can do this, but we know really, this on the right I think is actually most important. 25% of folks miss their appointments because they don't have a ride. So if you are an elderly or if you are young and you can't get to the appointment because a follow-up of a foreign body, as we heard, or something like that, the last discussion, what happens to them? How do we even know? And how can we put a social service in place to actually support that? We know that $8,000 are spent, or not spent, to help folks. And we know 39% people of children in Medicaid are more likely to visit the ED if they live in unrenovated public housing. But we don't necessarily know that they live in that type of environment. So what we did is we started gathering self-reported data and using different tools, just trying to map. If we could get to a higher level of specificity, could we actually do something? So we were saying, okay, well, let's figure out if we could actually understand what's happening to people, could we do something with that information? Go deeper, if you will. So based on that, in 2018, we were able to find 500,000 people. This is self-reported and us looking through data. 500,000 people that we were able to serve, and 700,000 social referrals. This is putting folks into systems that exist today and understanding at scale, once again, can we do something better for these people, for these patients? So, I'll give you an example, and for the clinicians, for sure you can understand this. You have a patient that's diabetic that has asthma, and that's what you see. And you don't know much more about them except that. Now, you can ask a lot of questions, but when you can really understand, is this person is an economic downfall, if you will, that they don't have stable housing, that they live in a neighborhood or have housing that perhaps isn't conducive to their asthma or controlling their blood sugar, then their level of risk, their predictive model, their ability for us to intervene and do something different is there now. I remember when I was in practice, I had this, and this is a very true story. I would write a diabetic patient, and I would write these prescriptions. And she was the sweetest lady. She was 67 or so. And I would always say, well, your A1C is like terrible, right? Your blood sugar control for the last 3 months is just terrible. And she would say, well, I get your prescription, and I take it to the pharmacy, and then I have to choose to eat. She chose to eat. And there was no way for me to capture that. No way for me to understand that at scale in a large part of my population, that was the issue. It wasn't necessarily, now we have some codes that say, at a higher level, but could we get deeper into say, what are those issues underneath? So this is what we're recommending, this is what our ask is. Could we go deeper and to capture and look at different social determinants of health? Why? So that we can better understand and intervene for our populations, for the folks that we all serve, to create a better overall outcome, condition, and intervention that we can take across. And we believe that accessing new codes can create that foundation. So, as I was saying before, we took those codes, all those reported codes, and we actually mapped them. So these are some examples of what we were able to do. 700,000 referrals last year to these types of programs. Just saying, hey, you might be eligible for transit. You might be eligible for neighborhood care. You might be eligible for some work that's being done in your community or nationally that can support you. So we've used these, and so we believe that these will be used. We believe that the data is actually there, but it's not captured in a way. We believe that utilizing things like HRAs or other areas to gather this data is readily accessible. And we also believe that we can then take that and create something better than what we have today. These aren't payer specific. This would be an industry ask, if you will. But the idea would be, as an industry, as a healthcare system, could we do better? Could we create more opportunity to serve the people that we are trying to serve? So, any questions? And yes.
Can you go back to slide 8? I might have missed this. I was taking notes. You say current code? Where are those from?
Oh, so we actually taken those codes. Those are the codes I'll use the word, codes we created within our system, just so that we could track, because we wanted to really understand, could we do something? Because if our ask is the same, we want to understand if we get to a different level of specificity.
Right, so you had created these codes.
Yeah, internal in our system.
Internally, and put them into your system.
And then, these are the new codes, if you will. So there's 23 codes we were asking, which I don't know I'm not going to go through those.
I'll
You want
do
me
that.
to?
I'll do
Okay. Because I will if you want me to. But I'm sure you'll do a far better job than I. So, but yes, so we'll just map those over. Yes, sir.
So for pediatricians, these problems that the parent has affect the child, but it's unclear from the codes how would because it looks like the way the codes are written, they apply to the person that's actually unemployed, et cetera. So how would a pediatrician use these codes?
Yeah, so I think if we look at some of the, unable for transportation, low income, unable to afford medications, there's some of those codes in there, but we'd be happy to continue to discuss and explore other subsets, if you will, adding different modifiers or other ways to identify the population.
On the subject of those codes, I'm Matt Menning, American Medical Association, here representing the Integrated Health Model Initiative, where we've been working with UHC, providing feedback and support on the proposed use and selection of I-10 codes. I've done quite a bit of research through the initiative in this space over the last couple of years, and broadly agree that the codes, the 23 codes we're not going to look at, are good codes for inclusion in ICD-10 in this context. It's our assessment that those codes will facilitate standardization of social determinants, which we believe is sorely lacking if we want to be able to make good use of this data, get us to a better assessment of social determinant risk, and at the end of the day, improve outcomes for individuals and populations. Our intent certainly is to take those codes, which the committee approves, and incorporate those into the information models around social determinants that we produce. So, thanks for doing that.
I'm still back on slide 8 with the current code. I understand that this is something that United Healthcare created internally. Are you pushing these out to your providers then and asking them to submit these? I mean, how are these turning up in your database?
So we have multiple systems of where we interact with patients. Some are visits at home that are done by nurse practitioners. Some are when we do HRAs where the nurses are outreaching and going through that process of being able to access. So we, I think last, that's 18, the number is actually remarkable on the amount of information that patients are willing to share with you around their personal environment. So,
maybe just to Sheila Shapiro from United Healthcare. I've been working on the initiative. Maybe I can add a little bit to it. Yeah, thank you. I actually have been working now in the provider space where we're taking information in from providers, so we're not trying to add administrative burden to an already burdened process. And we actually crosswalk it to a code for them so we can bring information in. That's really not the best solution to give information back, right? Because what we're doing and what we want the industry to do is be able to share a more comprehensive view of the person's health overall. And so to your point of, our pediatric codes identified there, probably not. What I would say that this is a beginning of a journey in a space that is new. So we certainly are not coming to you saying this would be an end-all be-all solution. This would be a start for us to look more comprehensively at that individual that we're trying to serve and get better clinical outcomes for. So we're not asking anybody to use those codes.
Jeff Lynch, speaking as an individual and not representing the Academy with this question. And I don't mean to sound snarky, but shouldn't there, with this type of proposal, shouldn't there also be a code that the person's in financial jeopardy because the insurance company's not paying?
I wrote that down.
That it's not a covered benefit. That's a different question, right? We administer benefits. So I think that it's a valid question, right? We're laughing at it, but there's an impact from the system cost, not whether we're paying a claim, but the cost in the system. And I think that there is an opportunity for us to uncover things that are affecting people's health that we don't know about today, and the socioeconomics of that affect people, right? Just like isolation affects people. And if you're unaware of that as a physician and the healthcare system in general, we're not able to really most effectively treat the people we're trying to treat. And that's really the beginning of this process in asking for these additional codes.
That's fair. And I think when you think, you said insurance company, but when you think broadly, Medicaid, Medicare, what's a covered benefit, to your point, we can understand. I mean, you were being snarky, but just think broader. But think broader, right? If you can understand that the Medicaid population can't get what it needs because it's not a covered benefit. Now, I'm not here to argue policy at all, but right now, is there a way for us to truly identify that?
Right, and there are people who are going bankrupt because they do have private insurance and a number of issues of lack of fair payment for coverage and things like that. So it may be covered, but there's certainly issues, and this is quite at the forefront right now.
Yes, sir.
Dick Hamburger, Renal Physicians Association. Who's going to provide this information to you?
So so that's a good question. So we've looked at multiple avenues, including the traditional, if you will, HRA, the health risk assessment, providers. There's, I think, multiple avenues. I think we have to get to not obstructing workflow, because I think our primary goal is to not make docs, if you want to call it that, do more work that they necessarily don't see the value add. So I know where you're coming from, right? But are there other avenues? Are there other ways that the data could be obtained? And I think that's what we're asking. But right now, what would we do with that data? Sheila, did you want to add anything?
So maybe just to augment that, where we do believe that adding codes into the system allows for more systematic information sharing. We found that not every physician, so certainly not to say this blanketly, but many physicians are utilizing some form of health risk assessment that sits in their EMR or sits in the record, but never gets communicated into the full system. And there really isn't a way for us, as we're now starting down this path of really helping people get the services that they need, that we're not able to share that back. So where there are existing codes, because there are several of them, this isn't brand new, we're not in total uncharted territory. When those codes, and I think Donna will talk about, the Blue Cross organization is asking to go deeper into nutrition for the same reasons, right? So that code exists, and when that code exists, we see that data flowing through on the claim today. What we're now starting to do is say, what can we do differently, knowing that information? And how, when we make that referral, are we able to provide that information back to you as a clinician, so you have the benefit of not only knowing that something was wrong, but that we're helping in that process by making that referral.
And I'll chime in there briefly as well. We are starting to see kind of massive scooping up of this kind of information, and often in ways that are burdensome on docs and not particularly useful on the other side. So our interest in this project really is, of course, from the doctor's perspective, and about ensuring that we're only collecting the meaningful data elements, and this is a good set, and then using them in a way that is standardized enough to actually provide some intelligence back to clinicians.
Nellie Leon, she's St. American Hospital Association. There's been a lot of interest in collecting information on social determinants of health. And as you probably know, there are many ways of identifying these things. So I was wondering, when you say you're collecting data, do you have a standardized set of questions that you've created, or what are you using? Because one of the concerns we've been hearing about is that you get what, depending on the questions, you get different answers, and you need specific definitions. And I understand that NCQA, the National Committee on Quality Assurance, last summer was putting together proposals to standardize the documentation and the coding of social determinants of health. They were looking for financial support as well, because they realized the importance, but also that unless you standardize things, you're just going to get garbage back.
Right.
And so I was wondering if you are part of that effort, or do you know where they're at? And I don't know the answer, because the person that within the AHA that was looking at that had not heard anything about it since the summer. So I just was wondering where you're at, because I would hate to sort of set something in stone in ICD-10 when there is this other process that may be happening concurrently that could come up with different variables in terms of what the codes would look like or what items you capture.
It's a great question, if I
Sure.
could. We've been working with NCQA since we began this work, and actually why they were trying to convene a industry representation is at our request. Because when we were trying to bring this forward, because we submitted this in the summer for the fall session, we actually wanted to bring more of the industry to the table, and they weren't able to take funding from us, an example where we couldn't give funding, in order to bring that collaboration together. But they have actually written endorsement to this design model. So we're not going in a contrary fashion. In fact, I was just there yesterday. They are moving in lockstep with what we're trying to do from a coding perspective, just as the AMA is. And we believe this is an industry issue that we have to solve for. And we've been trying to incorporate organizations as we can to bring a consensus to a potential model. It's not about asking specific questions at the beginning. As you get greater interest in level of granularity, then of course the specificity of the question is really important. Right now, at the beginning stages of this process, just knowing that somebody is food insecure gives you a starting place. Then what you're going to see with what Vermont is asking, they're trying to go deeper, right? Because the minute you start to know someone is food insecure, then you have to know more about that person in order to really try and assist in that particular area. We haven't asked for that level of granularity in this first pass because we know we're taking a big step and engaging this organization to start to address that coding as part of the clinician workflow. I'm sure people are going to want more granularity, just as with identifying items for children. There are many, many things we could have gone deeper on, even in food, because addressing food insecurity can be, helping somebody in an emergency situation through food stamps to congregate meals. You can go through a whole litany of things that maybe people would want to know the answer to, but you have to begin somewhere. And so NCQA actually is in direct support of what we're doing as it relates to using this model as a starting place.
I had one more question. So if these granular data are, if you do start to collect such data, would you see any need for either mechanisms or regulations to prevent the sharing of the data in ways that might adversely affect either the individual or the group?
Yes.
We have definitely started to have many conversations around the implications of privacy around the data. We are only sharing information if it's self-reported. So right now the person is sharing with us that they need help and that they're interested in getting that assistance. And that has, so we take that very seriously, at least within the work that we're doing. And we're making sure that we're not just blanketly attributing something at a population health level and saying because you happen to live in a zip code, we think this about you. This is all self-attributed.
And also why we're involved to a large extent. You're going to need mechanisms for knowing that permission was given. You're going to need expert advice to avoid building bias into the creation of these kind of codes, and we believe that's where we have a role to play.
And we're thrilled that there was such animated conversation because we want that. This is new, and we really are thankful to be here today, and are glad that there is consideration for the recommendations.
Okay, so we'll get into the coding proposals, but I also wanted to make some additional comments to kind of follow up to what Dr. Castillo and Ms. Shapiro and hi, Matt, have been talking about. There is a larger stakeholder discussion going on around this whole effort. Most recently, at the end of 2018, some of you may have heard about LOINC actually undertaking activities to look at this as well. They held an Advancing the Interoperability of Social and Behavioral Determinants of Health. They have a wonderful PowerPoint slide on their website that talks about the work that they're doing. So this work is happening in a variety of stakeholder groups, but we think that all of the stakeholders need to be heard and have a conceptual way of looking at all of this. And as I think AHA mentioned, it is making sure that we're talking, we're using the standardized vocabulary so that what goes in is standardized, but what comes out is standardized as well. And so in the materials that are posted on our website, we provided the background that United Healthcare has provided in support of the proposals that are included, but you'll note that NCHS, we are inviting comment from the stakeholder groups because we know it's a larger group than just the people who normally attend CodeSet developer presentations, and the use is very variable. There are multiple health assessment tools that use various vocabulary. This draws from some of the responses that you get. They're trying to standardize those, but some of the responses are patient verbatim responses. And so how do you standardize all of that? And that was the basis for a very good summit that was held at the end of 2017. That was jointly sponsored by Siren and the National Library of Medicine. So there's ongoing discussions here. And I think as Sheila Shapiro just mentioned, this is sort of likely the beginning of the discussion. And so we are inviting your input on this because it is such a broad issue and touches so many different aspects of the healthcare community. So with that, the material that was posted last night, or late afternoon, just to go through the codes that are being requested specifically by United Healthcare, and I have a separate proposal to go over with you as well. At Z56, problems related to employment and unemployment, there was a request for specific codes regarding the employment status. Oops, and I overlooked the expansion at Z55. New codes for problems related to education and literacy and whether the patient has less than a high school degree, a high school diploma, or a GED. Several new codes being requested related to low income, related to housing, and some related to stress. And I will note here, and we've had discussions about this, that some of these stress codes that are being requested already overlap with stress codes that are in the classification. So that's definitely something that has to be revisited because we do not intentionally create codes that overlap with existing codes. And it could be that there is some communication education needed in helping people understand what is already in the classification and how not to duplicate what is already there, but to get better use out of the codes that currently exist. I'm not going to go into...
If I could, please, I failed to mention, and I just think it's an important point, and I apologize for interrupting the flow, but the National Association of Community Health Centers is another organization that we have been collaborating with, and they actually not only are endorsing this, but are using this code set in their standard questions for all of their health risk assessments. And they did have input in the recommendations that you see here. So some of these are from their thoughts as well.
You said you're using the code set? Which one, this proposed one?
No, the Z codes that exist today.
In other words, I see.
To translate it to what already exists.
I understand.
Yeah. It's just where there's gaps. There isn't any way to share.
So Jeff Lenzer speaking as the representative from the AAP. We'll certainly look carefully at this proposal. We are concerned that it doesn't cover the pediatric population appropriately, and where, you know, if you make the comment this is a first step and then you're going to come back and fix it, I think it needs to be taken care of all in one sweep. I'm also concerned that in certain places you may need some instructive codings. For example, the unable to pay for prescriptions. We already have an underdosing due to financial hardship, and so there should probably be some coding instruction there. Also on the Z codes, on the stress, while they're a little nebulous in the terminology, it strikes me that those would fit either in the F or the R chapter as opposed to the Z chapter.
Yeah, and those are some of the conversations that we've already had. But again, before going down the path of revising and tweaking, we thought this might be the opportunity to bring this to a larger audience and also to continue to do outreach with some of the other groups that work in this regard because they've already provided their own perspectives and their own input as part of this larger discussion. So again, we invite your comments on this. Again, knowing that we'll likely, be revisiting this, having those comments by May, so that we can actually look at those comments and see where we might, be working to modifying these proposals and those that are still coming in, because there are other groups that are also, again, working in this area. I will also point out that when this larger stakeholder meeting was held in November, it was recognized that of all the things that regarding social determinants of health that people wanted, it was pointed out that there may be a number of different code sets that may be relevant in this, and that one code set may not be the answer. So LOINC, again, is already looking at this. SNOMED is already looking at this. So there are a number of groups that are working on this, but if we're to standardize and harmonize, I think it would be very helpful that all those groups are working together to come up with a win-win situation and not continue to be as siloed as they are, which continues across all of healthcare to be a major issue. So. Yes.
Sue Bowman from HEMA. Just as people are looking at this back to the whole standardization question, I think people should look at all the different ways, these codes could be interpreted, misinterpreted, in whose perspective, the provider's perspective, the patient's perspective, what does stressed quite a bit mean, and is that what the patient thinks he's stressed quite a bit, or the physician thinks the patient is stressed quite a bit? I was unaware being employed full-time was a problem. I hope there's someone here who could help me, resolve that issue.
Likewise, having a high school diploma.
And
I've got
perhaps
one,
that was
it's not a problem.
right.
Yeah.
Well, and perhaps I was looking at, they can't go to a medical appointment in the middle of the workday. On the other hand, I work at home full-time, so I have more flexibility in my workday. So that's a little different situation than somebody who's in a business environment all day. So I think there's a lot of different ways some of these could be interpreted, and I think that goes back to Nellie's and some other people's point about the standardization issue and perhaps instructional notes that would need to be included with these codes to try to put some framework as to how these codes are being used.
Thank you. Thank you, all of you, for your comments, and again, we want them in writing. Be careful what you ask for. Okay. But really, we would love to have your comments. I find the comments that have been made here are helpful, not just to us, but I think to the representatives from United Healthcare and everybody in the room who is dealing with these very important issues. So, and we have 10 minutes before we have to vacate the room, so I'd like to cover the food insecurity topic that was mentioned earlier. It's in part 2 of your handout on page 20. And again, a lot of the background that we've all just talked about more generally is applicable here. We do have the write-up from Blue Cross Blue Shield of Vermont and the Yale School of Nursing, specifically asking for codes related to food insecurity. They do talk about the concept of food insecurity being a much more mature concept from their perspective, and it is being captured in various health assessment tools, including some from the American Academy of Family Physicians, the American Academy of Pediatrics, and several other groups. And their request, let's see, there's about 5-6 new codes that they are requesting that are specifically related to food insecurity. At Z59.4, which is an existing code, they want to expand under that code and create unique codes for lack of adequate food, food insecurity, and lack of safe drinking water. Information is included in the background that talks about why they believe that those concepts need to be split and not grouped together. I will note that at Z5941, we have an error in the code title, and it should actually read lack of adequate food, which is basically what is described at the Z59.4 subcategory. So we will be making that modification. And under Z5941, excuse me, we'll be adding as an additional inclusion term, lack of food. Moving down to Z81.8, a new code is being proposed at Z8185, counseling for socioeconomic factors. And then at Z9111, a unique code, Z91110, patients' noncompliance with dietary regimen due to financial hardship. So again, we are inviting comment on this specific proposal, as well as comments on the overarching proposal submitted by United Healthcare. And again, May 10th, I know I'm going to sound like I'm repeating myself, and I am, purposely, because again, we would like your comments. It's very frustrating for everyone when you make good comments here, but then you don't follow up with your written comments, and we really do need the written comments. Dr. Linzer.
Since you're going to the Z91-110, wouldn't you need a Z91-118 other?
We would handle that as we go through this. Again, right now, we were just going to present specifically what the ask was from the submitter. But as these get fleshed out, yes, the unspecifieds and the other specified, those would also be added to the proposals. But for this presentation, we did not do that. Any other comments or questions on either the UHC proposal or the Blue Cross Blue Shield Yale proposal? Yes. Identify yourself, please.
Abby Mormon. For
the notation, should it be an excludes 2 versus an excludes 1? Because I would think that you could have malnutrition if you had few food insecurity.
So it excludes 2. We'd have to also look at, you know, the guidelines, because again, if you, the problem codes are exactly that. You have no further specificity. However, typically if you've been diagnosed with malnutrition, some of these codes in the Z chapter would not be assigned. So, but that's a good thing to take a look at, Abby. Thank you. And you'll put that in writing. Any other comments or questions? Okay, well, we have moved very smartly through a good number of proposals. We are supposed to be out of here at 11:30. It is now 11:25. Again, please take your belongings with you. We apologize, but there is a group coming in here for a meeting, and then we will reconvene at 1 o'clock and finish off the remaining 18 proposals. So you're not off the hook. We have quite a bit of more work to be done. Yes, we will be coming back. We're coming back here. Anyway,